Hi, welcome everybody. We're going to just wait a little bit to get some more folks in, but as you join, if you could answer some of the demographic questions that you're seeing, and you need to scroll down to see them. I think there are 3 of them. Thank you. Hi, everybody. I see there's more joining, so that's good. We're going to start shortly. You'll see some demographic questions. There are 3 of them. You have to just scroll down. If you could answer those, that would be great before we start. And then after we see that we have a good number, we'll get going. Okay, it looks like, oh, nope, some more coming in. So just welcoming everybody. We'll probably start in another minute, but as we're waiting for a few more to join, you'll see some demographic questions. If you could answer those, please. There's 3 of them. You just have to scroll down. That would be wonderful. Thank you. And we'll probably start in a few seconds. It's nice to see more people are trickling in. Okay. Well, if you just joined, if you do have the opportunity to answer the demographic questions, that would be wonderful. But I will probably get going. I just wanted to welcome everybody to today's webinar. The name of it, as you know, is Management of Substance Use Disorder in Pregnant People with HIV. I'm Sandra Springer. I'm a professor of medicine at the Yale School of Medicine in the section of infectious disease. And we are really, really, really happy to have introduced your presenter for today, Dr. Leah Leisch, who is an assistant professor of medicine in the Department of Medicine at the University of Alabama at Birmingham, an addiction medicine expert. And if you were lucky to have joined us at one of the prior sessions that was specifically about opioid use disorder in persons with HIV, you probably have heard her spectacular presentation. And if not, you will soon learn how to listen to that. So we are going to move forward. I just want to give a few overview slides. So we are just presenting here our financial relationships with ineligible companies in the last 2 years. So this is the content on the web board listed here. And then also for myself and Dr. Leisch. Dr. Leisch does not have any, and you can see mine are here. And also there are no financial relationships or related to the planners or the reviewers. We also are really happy to report the CME information. So on behalf of the International AIDS Society and USA, this is accredited by the Accreditation Council for Continuing Medical Education. So there are 1.25 AMA PRA category credits with this. And you can see this is approved up to 1.25 for the various organizations listed here. We're also happy to have support provided by the organizations listed here. And just a few, basic information for those who have not participated in this style of a webinar. So you will, if you have, you will see some poll questions like just popped up for the demographic questions. That'll come up in a separate window and you can just choose your response and then we'll be displaying those. And then if you yourself have questions, please use the Q&A button to put your questions in, and then I'll be asking those to Dr. Leisch at the end. And then the chat is open, but please try not to use that to ask questions through there. All right, so I'm really excited to turn this over to Dr. Leisch. Thank you very much.
Okay, you should be seeing my screen now. Are you seeing my screen?
Yes.
Yes.
Okay, good. All right. So this is myself, of course, and we already talked about I have no relevant financial disclosures. Hopefully by the end of today, on completion of this activity, learners will be able to screen patients with HIV who are pregnant for substance use, explain the complexity of the social and legal constructs impacting care for patients with current or past substance use who are now pregnant, and describe the U.S. Food and Drug Administration approved medications for nicotine cessation and opioid use disorder and how they relate to care of people with HIV who are pregnant, planning to become pregnant, or breastfeeding. So we will start with a poll. What is your prior experience with patients with HIV, pregnancy, and substance use disorder? A being, I do not see many patients with these conditions. B, I see patients with these conditions often, but have not managed the substance use disorder myself. C, I see patients with co-occurring pregnancy and substance use and have begun to manage it. Or D, I do all of this quite confidently. If y'all just want to let me know when that poll fills up. Okay. So some of you aren't seeing these patients yet. I think you may answer that differently by the end of the talk. And then some people are seeing these patients but not treating them all that much. A few of you feeling confident. All right, so let's start from there with a pretest question. So there's a 32-year-old woman with past medical history of chronic obstructive pulmonary disease, tobacco use, and intermittent methamphetamine use, who returns to clinic for routine HIV follow-up. She is consistent with her antiretroviral therapy, and her plasma HIV RNA level is below the limit of detection. She has recently learned she is approximately 6 weeks pregnant. Which of the following statements is true regarding the impact of substance use on her pregnancy? Methamphetamine, so I'll let you read those choices and pick an answer. I won't read them out to you. And I'm going to move on to the next question. Hopefully you've decided on your answer. So with question 2, oh, so we have everyone's answers there. I'm sorry. Thank you for showing that. So it looks like most people picked D, which was, I'll go back so you can see that. Decreasing smoking during any trimester can decrease infant all-cause mortality. That was the most popular answer, but with a few others in there as well. So question 2, I won't skip this until you all show me the responses. A 25-year-old woman with a past medical history of opioid use disorder has recently initiated methadone for OUD. After 2 months, she stabilized at 120 milligrams of methadone per day. Urine drug screens are consistent with methadone dispensed and negative for all other substances. Urine pregnancy test is positive. She's surprised and slightly dismayed that she was pregnant, as she wasn't expecting it. She asks if she will have to stop methadone if she continues the pregnancy. Which of the following statements is correct? A, she should consider transitioning to buprenorphine, which is associated with decreased severity of neonatal opioid withdrawal syndrome. B, she should try to taper her methadone dose toward the 3rd trimester due to risks for her and her infant. C, she can remain on methadone throughout pregnancy in the postpartum period and may even need to increase her dose later in pregnancy. Or D, she can stay on methadone during pregnancy but would need to stop if she desired to breastfeed. Okay, so a lot less certainty about that one. And we will talk about all of these through the talk, all the facts about this through the talk, and at the end, we'll go through this question again. What we won't go through in detail today is specific screening tools, specific ways to start or initiate medications for opioid use disorder. And that's because we have covered those in prior webinars. This is a list of the webinars in the substance use disorder series, and those are all available on demand through the IAS-USA.org website. All right, so the reason we're talking about this today is because substance use among women who are pregnant is common. The most commonly used substances are tobacco and alcohol. That's why I said some of you might be treating people with substance use and not realizing it. So tobacco use during pregnancy is substance use in pregnancy. The most commonly used tobacco and alcohol, with approximately 10% of women reporting past 30-day use of these in the 2019 National Survey on Drug Use and Health. The next most commonly used substance is marijuana, with approximately 6% of pregnant women reporting use in the past 30 days. And while numbers are smaller for opioids, it's important to note that over the past 15 years, the number of pregnant women with an opioid use disorder at labor and delivery has quadrupled. In addition, use of more than one substance is common. And so learning about the management of these use disorders becomes very important for our patient population. And when most people think of substance use during pregnancy, they immediately think of potential teratogenic effects of the various substances of misuse. And it is true that various substances are associated with a milieu of adverse delivery and infant outcomes, as shown here. For example, you can see tobacco use is associated with these conditions listed here, like cardiovascular deficits, limb reduction deficits, digit anomalies, club foot, etc. Alcohol, of course, is associated with the outcomes that combined together we call fetal alcohol syndrome, or when less severe, we call fetal alcohol spectrum disorder. Marijuana can be associated with ventricular septal defects, gastroschisis, and a variety of cognitive and psychiatric sequelae in offspring. Stimulants with limb reduction, ADHD, and impulsivity. And you'll see here under opioids, there's this asterisk that is there because when it comes to neonatal outcomes, opioids are an area where literature seems to go back and forth a lot, some indicating little to no teratogenicity, other population studies indicating clear associations with heart defects and cognitive deficits, particularly language and communication-related cognitive deficits that are more apparent as the child grows. Thus, studies may have varying results depending upon which study you look at and how long that particular study followed the offspring, were the opioids prescribed versus non-prescribed, the dose of opioids consumed, the trimesters of consumption, and many, many other factors. And that's a good segue to say that the reason I included this lovely cogwheel tree that you'll see to the right is that there are many things that contribute to the negative fetal outcomes, and the substances themselves are just one part of why negative fetal outcomes occur for a patient who has a substance use disorder. Oftentimes there is also poor nutrition, unhealthy living conditions, and limited access to healthcare, as well as stigma, which prevents them from seeking healthcare sooner, right? Along those lines, we know that prenatal care is important for maternal and fetal outcomes. And you can see here this lovely study published in Preventive Medicine, where the authors used data from the 2016 to 2019 Pregnancy Risk Assessment Monitoring System, or PRAMS, to assess month of pregnancy at which patients with varying reports of substance use began prenatal care. Here, you can see that women with substance use tend to enter care later than their counterparts with no substance use. This is particularly true for women with illicit drug use. In addition, in that same study, they observed that women who report prenatal substance use are less likely to receive adequate prenatal care or attend a postpartum visit. So just to explain these graphs here, you can see that this is the odds ratio of receiving care over here. Of receiving adequate prenatal care, and it is 0.29 for patients with illicit substance use. You can see down below that, the odds ratio of attending a postnatal visit is 0.47 for patients with illicit drug use. So overall, fairly poor engagement and retention in prenatal visits for those with illicit drug use. I'm sorry about that. This is important because use of opioids or stimulants during pregnancy is associated with increased risk of severe maternal morbidity. So not only is substance use during pregnancy harmful to the offspring, it's harmful to your patient. In this retrospective analysis published in Drug and Alcohol Dependence, the authors used ICD-10 codes to identify presence of substance use disorders during delivery and then assess for any of the 21 CDC indicators of severe maternal morbidity, for instance, heart failure, eclampsia, hemorrhage, or sepsis. You can see here that opioids and stimulants are both at both younger and older age are both including and excluding blood transfusion associated with increased risk of severe maternal morbidity. Interestingly, this association does not hold true for cannabis as a whole, although smoked cannabis has been shown to be associated with increased risk of placental abruption in some other studies. And if you're looking at the screen and a little bit confused by the lines, the red and blue mean nothing other than the fact that you have entered a different line. The top line will always be cannabis, the middle always opioids, and the bottom always stimulant. And then it's comparing any severe maternal morbidity at a younger age versus a older age, and then any severe morbidity excluding blood transfusion at a younger age and then an older age. And so that's the orientation of that graph. And since substance use in pregnancy is associated with such significant adverse outcomes, prevention should be paramount. Thus, providing adequate contraception counseling to patients with active substance use can be viewed as a form of harm reduction. In addition, assisting a patient in avoiding, reducing, or stopping the use of tobacco, alcohol, or other drugs prior to becoming pregnant is an important part of comprehensive care of your patients with HIV. So now, in order to assist the patient in reducing or stopping substance use, you would have to know who is using substances. This often brings up the question, who should be screened for substance use? Well, the World Health Organization guidelines for the identification and management of substance use and substance use disorders in pregnancy recommends that healthcare professionals ask all pregnant women about their use of alcohol and other substances. For instance, past, present, prescribed, illicit, illicit, as early as possible in the pregnancy and at every follow-up visit. And we'll talk a little bit later, a little bit more about that all. All right, screening for substance use in pregnancy is similar to screening for substance use in the general population. I am a person that likes to keep things simple, so one of my favorite screening tools is the NIDA TAPS tool. So that's the National Institute of Drug Abuse, Tobacco, Alcohol, Prescription Drug, and Other Substances. I like it because it's simple. You just ask, in the past 12 months, how often have you? And then you ask, used any tobacco product? Had 4 or more drinks for men, or 4 or more drinks for women, 5 or more for men on a single occasion. Used any drug, including marijuana, cocaine, crack, heroin, methamphetamine, hallucinogens, ecstasy, or used any prescription medication just for the feeling more than prescribed or that were not prescribed to you. So any of those 3 categories. And any positive answer, so anything greater than no to everything or greater than 0 is a reason to ask more questions about their substance use patterns. Similarly, another somewhat simple screening tool is the 5 Ps. This screening tool asks 1 question using 4 different subjects. And then it asks about alcohol or substance use in the past month. So it asks, did any of your parents have problems with alcohol or drug use? Did any of your friends have problems with alcohol or drug use? Did your partner? Same thing. And then asks for the patient and then asks about alcohol or substance use in the past month during pregnancy. Again, any positive response is a reason to ask more questions about their substance use patterns. So very similar to what we use in the general population. Like I said, its screening is similar to the general population with 1 exception. That is, depending on your state, you may be required to report the patient's answers to various authorities and may put your patient at risk for legal consequences. In fact, 25 states and DC require mandatory reporting. 24 states and DC define substance use in pregnancy as child abuse. 3 states include it as a grounds for civil commitment. And this can cause delays in care and is associated with an increased incidence of NOWs. And so while many of these regulations are well intended with a hope to decrease harm to the fetus and mother, data at this point actually would indicate that they do not improve maternal or neonatal outcomes. This graph is from the RAND organization, and it shows you which states have at the time of that publication, which states have punitive versus reporting versus testing regulations, in which states offer targeting programs. And that RAND organization is a good site for information on this, if you're looking for information. So not surprisingly, not with risk of punitive action known by patients, it's not surprising that none of the screening tools I just mentioned have very high sensitivity or specificity, as there's significant potential consequences of honesty in many states. And due to concerns about potential underreporting, some physicians become tempted to instead use urine toxicology as a screening tool. And particularly in pregnant women, urine toxicology it should not be done without consent, particularly during pregnancy. It is important to note that there was a landmark case called Ferguson versus City of Charleston in 2001. In this case, 10 patients from a Charleston hospital sued the hospital, individual medical personnel, the city, and law enforcement for performing drug screens without consent. The medical facility was testing pregnant women suspected of substance use, keep that in mind, suspected of substance use, in hopes of encouraging them to enter drug treatment. But recall that some states require reporting. So if positive, the results were turned over to social services, who then turned them over to law enforcement, and there were patients who were arrested. Ultimately, the Supreme Court ruled in this case that drug screening in that scenario violated the Fourth Amendment right against unreasonable search and seizure. It's also noted that suspected drug use screening was employed in very biased ways and disproportionately affected underrepresented minorities and people of lower socioeconomic statuses. And so, like I said, the World Health Organization recommends we screen all patients, and this is why. So one, because it's harmful to the fetus and the mother, and so identifying it early is important. But two, when we start screening just based on our suspicion, we tend to do it in a very biased way, whether that's intentional or unintentional. And so you should be screening with questions and validated screening tools. You should not be screening with urine toxicology. But if you are going to be doing urine toxicologies on your pregnant patients, you should be doing it with consent, and you should be doing it for everyone, not just suspected people. And so how do we obtain consent for urine toxicology? Usually I do that by talking to the patient and asking them questions like, what do you want to know about your blood or urine tests for substance use? And those used to screen for substance use as part of your prenatal care. And what, if anything, do you want to know about the effects of substances on your pregnancy? Would it be okay with you if we checked for some of those as part of your care and in order to help you? And because I do live in a state where mandatory reporting is required, I do let the patient know, just so you know, if it did come back positive, we would have to let social services know, because that's a requirement in this state. And so if you're not sure about your state, you can look at the RAND organization. You can also, for the most up-to-date information on the legal status in your state, consider contacting state chapters of the American College of Obstetrics and Gynecology or the American Society of Addiction Medicine. So they should be able to help you know what those requirements in your particular state are. Now that we've screened our patient for substance use, we need to know what to do with those results. Well, the foundation of care for pregnant patients with any substance use is a comprehensive patient-centered care plan. What does that look like? Well, from the provider standpoint, that looks like screening followed by brief intervention and referral to treatment. Then working with your team to make certain the patient has a safe living environment. This will mean getting case management involved early. It can also be beneficial to get recovery support services involved early. In addition, there are medications available for the patient's substance use disorder. If there are medications available for the patient's substance use disorder, provision of those medications is important. And then screening for applicable common co-infections such as HCV and HBV, particularly if IV drug use is involved. I've included here on this slide some important referral and support agencies you might want to make yourself aware of. The Opioid Response Network, this one up top, provides technical assistance to groups working to improve OUD care. CRAFT is an evidence-based approach to family communication around substance use. HRSA offers federal home visiting programs. Sorry about that. that offer early intervention services for infants, and the National Centers of Substance Use and Child Welfare is like a fount of information and a repository of resources. There are just some resources I wanted to include for any of you who may be adding substance use disorder services to your HIV clinic. So you can begin building your patient-centered comprehensive care plan with your team. And once you have all of that and counseling services arranged, we begin to think about what other treatments are available. So it's important to note that psychosocial interventions are the only available interventions for several substance use disorders during pregnancy. For marijuana, cocaine, and methamphetamines, this is because there are no FDA-approved medications for any patient population, pregnant or not, with those use disorders. For alcohol, there are FDA-approved medications, but those FDA-approved medications are contraindicated in pregnancy or considered to have risks that outweigh benefits. For instance, disulfiram and acamprosate may be associated with adverse fetal outcomes. Naltrexone is also relatively contraindicated, as there is not solid data to say that it helps decrease alcohol use during pregnancy. That being said, there is solid data to say it decreases alcohol use for the non-pregnant patient population, not solid data to say it decreases alcohol use during pregnancy. That being said, there is some move to reconsider this recommendation, as it is also not particularly linked to any adverse fetal outcomes, and in fact is sometimes used for OUD in pregnancy. The next question I'm often asked is, so what do you do for these patients when there is no medication available to help them? Well, as the title of the slide indicates, there are psychosocial interventions that have been shown to be helpful. For stimulant use, contingency management is still the most well-studied and most effective available treatment. Contingency management involves a proximal positive reward for a specific desired behavior. So in clinic, this looks like me asking my patients to come to clinic twice a week for drug testing. And if their drug testing is negative for stimulants, they are provided with a reward. And that reward escalates each time they are consistently negative, and the reward goes away if they're ever positive. This does tend to take some special funding, usually through grant support, because most insurers don't cover it. But again, it is the most effective treatment that we have available for stimulant use disorder. All right. It does also have efficacy for other use disorders, so you can also try it for marijuana and alcohol as well. For tobacco and alcohol screening and brief intervention alone can also be highly effective. Something like 56% of people who find out they're pregnant quit smoking just because they found out they're pregnant. And so just that screening and brief intervention and counseling for smoking cessation are effective, and they can be simple. And so that brief intervention may look something just like information about smoking related risks from physicians, frequent follow-up, use of a pregnancy-specific or other self-help manuals, and sessions with a health educator, or videos or podcasts on smoking risks and cessation. However, despite being effective and simple, it's estimated that only 49% of obstetricians routinely advise and provide follow-up for smoking cessation. Furthermore, only 28% discuss actual strategies for cessation. So there's definitely room for improvement there. But assuming you were one of the awesome 28% that screened and effectively counseled your patients, and yet your patient is still smoking, should you prescribe them a medication? The ACOG stance on medications for smoking cessation in pregnancy is that there is sufficient data to say that smoking is indeed harmful, and some data to say that medications for smoking cessation are not harmful or not as harmful as smoking itself. However, there's insufficient data to say medications for smoking cessation are helpful during pregnancy, as 50% of patients who smoke quit without medications just prior to onset of pregnancy. And so we know that the medicines should be safe to use during pregnancy. We know that they do help some people who aren't pregnant quit smoking. We're not sure how much they help people who are pregnant quit above and beyond those who already quit because they found out they were pregnant. Does that make sense? I hope so. That being said, the experts agree that you should consider them each on a case-by-case basis. And if a patient is highly motivated but still struggling, any of the 3 medications could be considered. So I'm going to talk about those somewhat briefly. Recall, nicotine replacement comes in many forms. Notably, only the FDA-approved formulations are recommended. So for instance, vape pens do not count as nicotine replacement, but gums and patches and lozenges do. Dosing of the FDA-approved forms of nicotine replacement is based on current smoking pattern, with heavier smoking requiring higher doses. Nicotine replacement is started on the quit date and is typically continued for 8 weeks, although in the non-pregnant population, it's been studied for up to 24 weeks. It's important to recall that there's increased nicotine metabolism during pregnancy, which may be why it doesn't seem to be as effective for pregnant people as it is in the non-pregnant population. Bupropion for smoking cessation can also be considered in pregnancy and breastfeeding. This is usually started at 150 milligrams and up titrated to 150 milligrams BID fairly quickly. We avoid use of this in those with a history of seizure, eating disorders. The most common side effects are insomnia and dry mouth. Patients usually start this 1 to 2 weeks before their quit date and are treated for 12 to 24 weeks. It's important to note here that bupropion at 300 milligrams is detectable in very small levels in breast milk, but this is not felt to be high enough to cause any adverse effects to the infants who might be breastfeeding. Varenicline is also approved for use in smoking cessation and can be considered in pregnancy and breastfeeding, with a little asterisk there. The starting dose is 0.5 milligrams with up titration to 1 milligram BID. It is contraindicated in those with severe mental illness, although it is notable that the black box warning for severe neuropsych effects was removed. Most common adverse effect is nausea and vivid dreams. It is usually begun 1 to 5 weeks before the patient's quit date, and because I am a person who likes to keep things simple, I just remember that I have to start either bupropion or varenicline at least 2 weeks before the patient's quit date. And patients are normally treated for 12 to 24 weeks. Note here that there is less data about the safety of varenicline in breastfeeding, and so ACOG, while not prohibiting varenicline during breastfeeding, does recommend considering an alternative agent. And part of that is just because we have less data. Remember, we do use bupropion for other indications like depression and off-label for ADHD and things like that. So there's just more people on bupropion for us to have sort of incidental data that it's safe to continue during breastfeeding, whereas we do not have that data for varenicline. All right, and so this is just a summary slide of what we just spoke about for the past 3 slides. We're not going to go over it again. I just put it here side by side, all 3 medicines, for those of you who want one screenshot for a cheat sheet for later. So there's your cheat sheet, and we're going to move on. The next thing we're going to talk about is opioid use disorder. The rate of maternal opioid use in the United States has risen drastically since 2010. You can see here on the left the maternal opioid-related diagnoses per 1,000 deliveries in 2017, and on the right is the percent change in those. Even in less affected states, the percent change is greater than 50%, and on average, the percent change is 131% across the nation. This means now more than ever, we need to be prepared to manage opioid use during pregnancy. So how do we do that? Well, first, I'm going to teach you what we don't do. First things first, medically supervised withdrawal from opioids as a form of treatment is not recommended. There initially were early reports of fetal distress and even fetal death due to withdrawal. And while this remains true for untreated withdrawal, meaning just giving the patient no medicine and letting them sort of suffer through it, more recent would suggest that medically managed withdrawal has no clear association with fetal death or preterm birth. This means that we are actually supporting that patient through their withdrawal symptoms. However, despite no clear association with fetal death or preterm birth, medically managed withdrawal is still not recommended as a form of treatment because the relapse rate after medically supervised withdrawal without subsequent continuation of medications for opioid use disorder is 59 to 90%. And relapse represents a risk for infection, death, and other negative consequences. And I think it's important to define medically managed withdrawal. Medically managed means giving medications to help manage the withdrawal symptoms. This may include non-opioids, but may also include a few days of buprenorphine or methadone taper. But again, these very short tapers of 5 to 7 days of these medicines are not recommended because of the very high relapse rates. So if medically managed withdrawal is not recommended, what is? Well, just like in the non-pregnant population, medications for opioid use disorder are recommended because MOUD saves lives. If you watched our first few sessions on the topic of OUD, you've already seen this graphic, but for those who haven't seen it yet, simply put, untreated opioid use disorder has a death rate about 6 times that of the general population, and you can decrease that to less than 2 by using FDA-approved medications for the management of opioid use disorder. This should also be a somewhat familiar graph if you've watched the other webinars, but there are 3 FDA-approved medications for opioid use disorder. For more information about starting these, please see those prior talks in this series. I'm just going to use this graphic to give you a brief background on the use of each of these during pregnancy. After that, I'll show you some data on the benefits of MOUD during pregnancy, and then a chart comparing and contrasting these 3 medicines during pregnancy. And so if you don't hear exactly what you're trying to hear during my little spiel on this talk, don't get anxious. I have several more slides. I just wanted to orient you first. Okay, so for the general background of these drugs, first, methadone. Methadone can be continued. Remember, that is the full mu opioid agonist. It can be continued and initiated during pregnancy. Recall, you would not be prescribing this. It would be being dispensed through a federally registered opioid treatment program, what some people call a methadone clinic. Please recall it does have drug-drug interactions with some antiretroviral therapy medications, particularly nevirapine and efavirenz. Both decrease methadone levels by increasing its clearance through liver enzymes. Thus, expect you may need to work with the patient's opioid treatment program if you add or remove those particular ART medications from the patient's regimen during treatment. In addition, it's important to note that toward the 3rd trimester, there's increased clearance of methadone due to increased cardiac output and circulating blood volume. This is typically managed by increasing the patient's methadone dose and sometimes splitting it, meaning the patient would take some in the morning and some in the afternoon. The dose is then generally decreased back to maintenance doses shortly after childbirth. Next, we'll talk about buprenorphine. Buprenorphine can also be begun or continued during pregnancy. Historically, the monoproduct version, i.e. the version without naloxone, has been preferred for during pregnancy. However, there is now more and more data to say that the buprenorphine naloxone combo product is probably fine to use during pregnancy as well. Data on the injectable extended release versions is still a bit pending, and we're going to talk a lot more about that later. Lastly, naltrexone. You'll see here that this is relatively contraindicated during pregnancy. By relatively, what I mean is that it is not recommended to start naltrexone for OUD during pregnancy. This is in large part due to the need for the 7-day opioid-free period and the risk of relapse during that time, as well as the problems that opioid blockade could create for pain control around the time of delivery. However, if a patient is already on naltrexone and strongly wishes to remain on it, this can be considered, as destabilization of the OUD is really considered the worst-case scenario. Patients should just be educated on the risks, benefits, and alternatives of remaining on naltrexone versus switching to buprenorphine or methadone during their pregnancy. Okay, so why do we care about those drugs? And what are the risks, benefits, and alternatives of them? So the benefits of being on MOUD during pregnancy in this lovely study from Addiction shows that the probability of overdose decreases with each additional week that a patient is on medications for opioid use disorder during pregnancy. In addition, the probability that the patient will remain on MOUD after pregnancy increases with increased duration of MOUD during pregnancy. And we know that remaining on MOUD is associated with less illicit drug use and improved social function. In the same study, there's an association with maternal benefits. So you can see here from the same study, the probability of preterm birth and low birth weight both decrease as duration on MOUD during pregnancy increases. We also know that being on MOUD in general decreases severity and duration of neonatal opioid withdrawal symptoms. There are some differences among the MOUD in this, and which we'll talk about in the next slide. So here you will see advantages and disadvantages, just as I promised in this slide. So advantages of buprenorphine are that infants born to mothers on buprenorphine, as compared to methadone, have decreased NOWs, increased birth weight and length. Buprenorphine also has inherent advantages, such as allowing for more flexible dosing, since it can be prescribed and doesn't have to come from the OTP, less drug-drug interactions, a ceiling effect on respiratory rate, and it is potentially helpful in preventing overdose. The disadvantages, potentially directly helpful. All of these prevent overdose by preventing relapse to substance use, but even if substance use were to occur, Buprenorphine, because of its high binding affinity, can block out some of the fentanyl and help protect against overdose, even if substance use were to occur. The disadvantages of buprenorphine are that given it can be prescribed, it is associated with treatment settings that are generally less structured than an OTP. In addition, in the fentanyl era, some people feel that buprenorphine just does not provide sufficient management of cravings. That's not the majority of people, but it is some. Also, being a partial agonist, it can cause precipitated withdrawal. And so you do have to have a period of induction where you get on it. It's also sometimes more expensive for patients. Advantages of methadone are that it is the oldest drug with the longest duration of data. OTPs provide a lot of structure for patients, which some patients thrive in. There's no need for a withdrawal period for methadone before induction, as there is with buprenorphine, because there's no risk of precipitated withdrawal. Disadvantages of methadone are that there are more drug-drug interactions. There's less flexible dosing because it has to come from an OTP, and sometimes there are significant drive times and distances. There is also increased neonatal opioid withdrawal syndrome symptoms compared to buprenorphine, but still way less than compared to heroin or fentanyl. So I don't want you to hear like, oh, methadone causes bad nows. It causes slightly more nows than buprenorphine, but way less nows than active drug use. All right, advantages of naltrexone is that it has no risk for nows. It's very few drug interactions. Disadvantages include the need for prolonged opioid-free period prior to induction and higher risk of overdose if there is return to use. So not only does it not protect against overdose, it can put you at risk for overdose if the person stops their naltrexone and has returned to use, and may make peripartum pain control more challenging. Not impossible, but more challenging. All right, so for those of you who prefer flow diagrams to charts, this is essentially how I think through deciding what, if any, MOUD is appropriate. I ask myself, does the patient have opioid use disorder? If they don't, then MOUD medications for opioid use disorder are not appropriate, right? If they do, then is this patient already on a medication for opioid use disorder? If they are already on a medication for opioid use disorder, if that medication is naltrexone, I talk to them about staying on it or possibly changing to buprenorphine or methadone, simply because those things we just talked about. If they're on an MOUD and that MOUD is buprenorphine, we discuss options of remaining on this or changing to methadone. I will say, by and large, we recommend continuing a patient on whatever medication they're on when they get pregnant if they're stable. Because if they are stable, there's no reason to change it. Right? The only reason we would talk about changing to methadone would be if this person were on buprenorphine, but still having ongoing drug use and feeling like the buprenorphine was not controlling their symptoms well. If they were on an MOUD and that MOUD was methadone, we would discuss remaining on this and prepare the patient that the dose will likely need to be split or increased later in pregnancy. Methadone, remember, does have those drug-drug interactions that we talked about, so do keep those in mind, particularly if you're altering those during pregnancy, which is already going to alter their methadone metabolism, the pregnancy itself, right? We discourage switching from methadone to buprenorphine during pregnancy because it puts the patient at risk of precipitated withdrawal. That being said, many women ask about switching from methadone to buprenorphine during pregnancy because if they haven't yet heard that buprenorphine causes less neonatal opioid distress, they will hear it at some prenatal visit or something they read online, and they will worry about it because that's what women who are pregnant often do, is we worry about what's going to happen to the offspring. And so we generally counsel women that stability is the most important thing. Neonatal opioid withdrawal can be treated. Precipitated withdrawal isn't good for baby either. And so it's better to just stay on it. If they're emphatic that they want to be switched from their methadone to buprenorphine, I would say that's probably something you want to consult your addiction medicine friends for, or familiarize yourself with the microinduction protocols that were presented in one of the prior talks about buprenorphine induction during the fentanyl era. But again, we don't generally recommend it. We prefer patients to stay on whatever they're currently stable on. All right, if your patient is not on a medication for opioid use disorder, then we discuss MOUD options and we initiate buprenorphine or methadone and plan to continue that through pregnancy and the peripartum period. And I advise the patient it's okay to continue while breastfeeding. Okay, that's how we think through it. All right, so let's talk just a little bit about extended release buprenorphine in pregnant women. The initial study on extended release buprenorphine in pregnant women was concerning. One of the original studies used the once monthly 300 milligram dose, which we tend to call Sublocade. The demographics for this study are shown here. You can see the first 3 patients were all relatively young, all previously on 16 milligrams sublingual buprenorphine, and all stable for at least 5 months, 2 stable for greater than a year. You may be noticing that this is a very small patient population. That is because this study was stopped early after the first 3 participants reported adverse events and declined the second dose. You can see that the first 3 participants, all 3 reported feeling euphoric on days 1 to 3. All 3 reported withdrawal symptoms on days 6 to 10. One felt triggered to seek illicit opioids due to the euphoria. One felt triggered to seek illicit opioids due to the withdrawal. All required increasing supplemental sublingual buprenorphine on days 7 to 28, and all declined the second dose. All of all 3, right? So criticisms of this study were that it was stopped after only 3 patients. That's a really, really small patient population. And the reported experience in this study conflicted with the experience of some clinicians in practice. And so many clinicians who were in practice who had patients who were on this medication said, well, I understand your 3 patients had this, but my patients who've had this medication didn't have that experience. Also, it's not unusual to require supplemental sublingual buprenorphine during the first 1 to 2 months of the injectable extended release buprenorphine products. In fact, we kind of presume that's a given even in non-pregnant people. And so it was encouraged for there to be more studies on this. And in fact, there is a subsequent study being performed in pregnant women using a different formulation of extended release buprenorphine that comes in weekly and monthly options. We tend to call this Brixadi. This is called the medication treatment for opioid use disorder in pregnant and expectant mothers, or the MOMS study, using the CAM 2038, which is that weekly or monthly version. The first 2 patients from that study are presented here. In case 1, the patient presented around 25 weeks of pregnancy. Her drug of choice were non-prescription opioids. She was previously on 8 milligrams BID of sublingual buprenorphine. She was given the weekly 24 milligram dose of this medication, injectable medication. And in between week 1 and week 2, as well as in between the next 3 weekly visits, she required a supplemental 8 milligram dose, and that was a sub-Q extended release dose, so kind of stacking those sub-Q doses. Ultimately delivered an infant at 39 weeks. The infant was monitored for 7 days, but required no medications, and the mother continued at her same 24 milligram weekly dose in the peripartum period. Case 2 shows a patient who presented around 18 weeks using non-prescribed oxymorphone. She was started on 12 milligrams of sublingual buprenorphine and referred to this study, but didn't get her first study injection until approximately 24 weeks. She continued on her dose, which I honestly couldn't find in the paper, so I'm not sure which dose she got at her weekly injections, but she got a dose. She did not have adverse effect or seem to require intermittent doses between that. Between her weekly visits, she did have some injection site reactions, which were treated with topical hydrocortisone. She had delivery of her infant at 35 weeks due to eclampsia, and the infant required opioids for neonatal opioid withdrawal on day of life 3 through 11, but was ultimately discharged to home. So things I took away from this little case report here is we probably can use extended release buprenorphine safely in pregnancy, but you will likely need supplemental dosing during the first 1 to 2 months. Again, that's similar to non-pregnant patients. You may see injection site reactions. The gravid abdomen can be used as an acceptable site for injection of these weekly or monthly injections, as can the arms, but they don't recommend using the arms until after a month of weekly dosing because it's associated with a 10% lower plasma level than the other sites. So you can rotate among that abdomen and arms. So this study gives us one more tool in our tool belt for managing our patients with opioid use disorder. And I will tell you from clinical practice, some patients do really prefer once a week or once monthly dosing because they want very badly to break the habit of starting every day with this thought of needing a medicine. And we sort of try and tell them if you're taking it just as prescribed, it's a medicine and not a drug, but some patients just really prefer the option of an injectable delayed release one, so that they don't have to think about the fact that they ever used drugs on a daily basis and only have to think about it once a week or once a month. And so it's nice to just continue to add tools to our tool belt. All right, and we will talk briefly about medications in breastfeeding. So I'll add that breastfeeding is beneficial in women taking methadone or buprenorphine and has been associated with decreased severity of neonatal opioid withdrawal, less need for pharmacotherapy in the infant, and a shorter hospital stay for the infant as well. So please encourage your breastfeeding patients. Please encourage breastfeeding in your patients with OUD while they're on MOUD, provided no other substances are being used. So for instance, they're not, on stable from an OUD standpoint using MOUD, but also using methamphetamines, right? So if their other substance use is stabilized and their OUD is stabilized on a medication for opioid use disorder, it is not only safe, it is encouraged that they breastfeed. On that note, one last thing I will say about opioids is really quickly regarding opioids is that naloxone for overdose is indicated in pregnancy. I know some people worry about causing precipitated withdrawal with naloxone if they give it to a pregnant person, and that then the precipitated withdrawal will potentially cause fetal death or preterm birth. But again, one more recent data suggests that if we medically manage that withdrawal, there's no clear association with fetal death or preterm birth if we medically manage it. And so we just make sure that the patient goes to the hospital after they get Narcan. But two, most importantly, if the mother dies, the infant does as well. So don't be afraid if your pregnant patient has an overdose, that they get Narcan, and educate them on that and make sure they have naloxone around the home. Okay. And I could not do justice to a talk on substance use in pregnancy if I did not address stigma. I know I don't have to lecture HIV providers on the importance of stigma too much, but just for review, stigma comes in many forms, all of which are harmful. Stigma can be structural, such as the criminalization of substance use in pregnancy or the limited availability of substance use care for pregnant patients. So there are many buprenorphine providers who won't treat people who are pregnant just because they're pregnant and they're uncertain of that themselves, but that becomes a barrier to good care. That's kind of a version of stigma. Stigma can also be public, and so this can be sort of loss of friends or family. It can be judgment from their friends or family. It can be views on their fitness as a parent. And so there's huge stigma around people's fitness to parent when they have substance use during pregnancy. Also, stigma can be sort of self-inflicted. And so mentioning views of fitness as a parent, I will say no one judges a pregnant woman who's using substances more than that pregnant person themselves. You cannot think more poorly of them than they already think of themselves. And so our job is to try and fight that so that they aren't stuck in their self-stigma and get the care they need. Also, patients who are using substances during pregnancy often feel undeserving of the care they get, and that can lead to relapse because they just don't feel worth sobriety or that they're capable of it. Remember that change does not just involve a desire to change, it involves a feeling of self-efficacy. And so if they feel that they're not capable, they won't try, not because they don't want whatever it is, but because they have no self-efficacy. Lucky for us, fighting stigma can be easy. We can fight structural stigma by expanding substance use care for patients with SUDs, remove criminal penalties for SUD in pregnancy, advocate for improved child welfare services. We can fight public stigma by educating families on how to support patients with substance use and the science of addiction as a brain disease, and connecting patients to support groups. We can also fight self-stigma that way by educating patients on the science of addiction as a brain disease, and that it's treatable, and use a strengths-based approach to parenting during parenting and pregnancy, and consider involving a peer. So all pregnant patients, I'm so sorry, should be screened for substances. The summary should be screened for substance use using screening tools, not toxicology screens. All patients using substances while pregnant should receive brief interventions and referral to treatment. Patients who are smoking while pregnant and have not achieved cessation with counseling should be offered medications. Patients with OUD should be offered and or continued on MOUD throughout pregnancy. You'll notice for smoking, we try counseling first, but for OUD, we do not. Medications, it's not like try abstinence only, and if that doesn't work, then try MOUD. For patients who have OUD, they should be offered and or continued on their medications throughout pregnancy and the peripartum period, and it is safe to continue during breastfeeding. Note that methadone has drug-drug interactions with some of your medications to treat HIV, particularly nevirapine and efavirenz. So our post-test question, a 32-year-old woman with a past medical history of chronic obstructive pulmonary disease, tobacco use, and intermittent methamphetamine use, returns to clinic for routine HIV follow-up. She is consistent with antiretroviral therapy, and her plasma HIV RNA level is below the limit of detection. She has recently learned that she is approximately 6 weeks pregnant. Which of the following statements is true? And I think you're all answering, and we'll talk about the correct answer. Are we ready? And so the correct answer is D. Methamphetamine and tobacco use are both associated with risks to both. There we go. To both the fetus and the parent. So one of those answers was wrong because it said just the fetus. Tobacco cessation is beginning on this at the beginning of the second trimester, not the third. So one of the options said the third, can decrease the risk of stillbirth to that of patients who do not smoke. But decreasing during any trimester decreases infant all-cause mortality. And so even if the patient doesn't stop until the third trimester, it doesn't decrease down to that of a non-smoking patient, but it decreases it from someone who's still smoking. So that is answer D. All right, post-test question 2. A 25-year-old woman with a past medical history of OUD has recently initiated methadone. After 2 months, she stabilized at 120 milligrams. Urine drug screens are consistent with methadone and no other substance use. Urine pregnancy test is positive. She is surprised and slightly dismayed. She asks if she will have to stop the methadone if she continues pregnancy. Which of the following statements is correct? She should consider transitioning to buprenorphine. She should try to taper her methadone, or she can remain on her methadone and might have to increase it, or she can stay on methadone during pregnancy, but we need to stop for breastfeeding. Tell us your thoughts there. Bonus points if any of you can tell me why she's dismayed, why she's surprised during the discussion. Okay, all right, so the correct answer is C. Medications for opioid use disorder, including buprenorphine and methadone, should be continued throughout the duration of pregnancy. Although buprenorphine is associated with decreased neonatal opioid withdrawal syndrome and increased birth weight and length, switching from methadone to buprenorphine during pregnancy is not recommended due to risk of precipitated withdrawal. Due to increased circulating blood volume and cardiac output in the third trimester, methadone metabolism increases. So patients who are receiving methadone while pregnant often increase their methadone dose during the third trimester. Methadone is indeed safe to continue during breastfeeding, as is buprenorphine. All right, questions and answer session. And I will stop sharing.
Thank you, Dr. Leisch. That was wonderful. And you said there was a bonus question that you gave there. Did you want to share?
So I will share because it is something that's important to me. So for those of you who don't know, long-term opioids, so this includes both illicit opioids and prescribed long-term opioid therapy, affect the gonadal axis and so can decrease fertility. And so patients who've been using really high dose, fentanyl or whatever, and who then stabilize on methadone or buprenorphine will often have returned fertility. And so some of these patients think that they're infertile because they started using at some young age and they've not gotten pregnant yet, and they just think that they're infertile. Maybe their menses have stopped, and then are very surprised when suddenly they find out they're pregnant. They're like, how did this happen? And so it's now my practice that whenever I'm initiating medications for opioid use disorder in a reproductive age female, I educate her on that and offer contraception, just so at least they know. right?
That's great. Yeah, no, thank you for sharing that. And I'm not sure how many of the audience was aware of that, but I think that's another really important tidbit that I think everybody would appreciate. So it was a spectacular, in my opinion, lecture. And I know you had to overview all of the substances. But there is a particular, I just was going to start with some of the questions that came in on the Q&A, starting with the beginning of your presentation about tobacco use disorder, and then we'll end up with questions about opioid use disorder. But the first question was in discussion about the use of bupropion for tobacco use disorder, also, obviously, as you know, as you reported, to co-treat depression. And one of the comments was, and questions was, whether having some second thoughts now after hearing your lecture, if should be having a discussion more with their patients if they are on bupropion and become pregnant, if they should be tapering off the medication. And if so, how would you monitor their symptoms, their mood symptoms for depression? And do you see many patients who prefer to resume it even if they successfully quit smoking?
So if I have a patient who's on bupropion, do I per se counsel them to taper that if they become pregnant? So not necessarily. And to me, it sort of depends on the severity of the depression that it was started for. So if this was major depressive disorder where they've had suicide attempts or psychiatric hospitalizations, I would say no. Because again, stability is the key, right? If this was maybe a little bit of seasonal affective that they got started on 5 years ago and no one's just addressed it, then I would talk to them about, hey, what do you think? But I'll be honest, most of the time the patient is the one bringing that up, because once people become pregnant, they become very aware of what medications they're on and how it might affect the fetus. And so if I do decide to taper someone, I really just monitor for those increasing depression symptoms. We tend to use the PHQ-9 in our clinic and just see if that gets any worse over time. And I have a fairly low threshold to restart if needed, particularly if the patient has more severe depression. And then if people want to restart it after pregnancy for smoking cessation, or even if they've quit smoking, I just treat it like a non-pregnant patient. And if it's indicated, I started.
Yeah. No, that's great. And I think it's a good reminder that some of the tools that we might use, say, for research purposes or other things, the PHQ-9 is a nice measure for actual clinical care and depressive symptoms. And then it's validated to follow. So I think that's wonderful. So thank you. There's a lot of questions that came in before your session, and I think you might have answered them, but a substantial number were regarding the treatments for opioid use disorder. And I think you went through their safety profile. That was one of the concerns. And they just were wondering which one out of the three do you think is the safest? And you can answer. I think you went through this, but if there's any tidbits or other information that you wanted to say about that.
So I tend to think of this in two buckets: those who are not stable on an MOUD. If they are not stable on an MOUD, I will tell them buprenorphine is the one associated with it has better retention and treatment than initiating naltrexone, right? And so it's better than naltrexone in that regard, and it has less neonatal opioid withdrawal than methadone, and so it's better than methadone in that regard. And so it has a little bit of a thought of superiority in my mind for people who aren't yet stable on an MOUD. For anyone who's stable on their MOUD, again, the best you could hope for in changing it would be the same. And alternatively, you might get worse. And so I just continue whatever they're on, if they're already on something unstable.
Yeah, and I think you made a very good point, and I really liked how you compared them and you went through all the caveats. And that's, it's important to say, and then the biggest thing is don't stop
Do
treatment.
not stop.
Right. And I think that's a really important aspect.
And women will ask, because again, similar to the bupropion, people will be on 100, 120 milligrams of methadone and be like, how fast can I taper this? And it's, I mean, it's wonderful that they're concerned about their infant, but it becomes our responsibility as a physician to say that that's actually not a great idea.
Right. And sometimes that involves actually, they might be getting some pressure too from family members, the partners, others. And really sometimes, in my in my experience, and I'm sure you've have more experience than I do about this, is just really seeing if they want those individuals to come in and to provide some education, or providing them with resources to bring back to their family members, just so
Yes.
they know that it's safe. Yeah. And that oftentimes is what we're doing. There were some, one question was, do you have any data or anything that you specifically, this was outcomes of infants born to women with substance use disorders. I think you reported a little bit on that, but I think maybe just add on to that, the caveat is outcomes of individuals who are on substance use disorders and treatment, too, as a comparison.
Yes. So first, whenever we look at information for infants born to women with substance use disorders, there are so many confounders that it's hard to say what drug is causing what effect, and if it's the drug itself at all. One, because co-use is common, particularly tobacco, opioids, tobacco, and we know tobacco is bad. And so it's hard to tell what drug is causing what, and because of the co-use of other substances, also because of the living environment, the stress level, other co-prescribed medications. Remember chronic pain and mental health disorders co-occur frequently with substance use. And so they're often on other medications that are sort of pregnancy-C. And so it's really complicated to know what's associated. What we do know for sure is that patients who are treated for their substance use disorder have better infant and maternal outcomes than patients who are not treated for their substance use disorder during pregnancy, which makes sense, right?
Right. Yeah, and I think that's got to be like some of the bottom line, is that to continue to offer treatment, and if they haven't been offered treatment, to provide that. We had a couple of questions about stimulant use disorder. One that came in before, you already addressed this. So one question had been for somebody who had a methamphetamine use disorder, is there any medications that can be offered in those situations? Now, you mentioned that there are no FDA-approved medications for treatment of stimulant use disorder. And then there has been a prior series that we had on stimulant use disorder by Dr. Shoptaw that anyone can listen to. But I think there are some recommendations, right, for medications from the American Society of Addiction Medicine and AAAP that can be used in non-FDA approved situations, but maybe a caveat about pregnancy. And then of course, I think another question to tie into that is about the contingency management and what types of incentives you might use so those two questions about medications potentially that you can or can't use in pregnancy, and then for stimulant use disorder, and then the contingency management question.
For medications for the management of methamphetamine use disorder and stimulant use disorder in general, there are no FDA-approved medications. There are some medications we try for methamphetamines in particular. The most promising data thus far is with Q3-week IM naltrexone. So that's that 380 milligrams once a month, every three. They actually use it every 3 weeks in the study they did. Long-acting injection with higher dose bupropion, so 300 to 450 milligrams per day. And so that's the best we know. And again, we already talked about naltrexone and bupropion in pregnancy because we were talking about them for other indications. There are some population level cohort studies looking at patients prescribed extended release stimulants, so like extended release methamphetamine salts and whatnot for stimulant use disorder. I will say I see the data go back and forth enough on that one that I personally have not yet walked down that pathway with my patients with methamphetamine use disorder, just because in some of the papers, the number needed to harm is similar to the number needed to treat. And so I've just been a little slower to embrace that. I'm excited to see what the future holds. Maybe in the future we'll be doing that. I'm not sure if I would jump to doing that in someone who's pregnant though, just because the risks of the extended release amphetamine itself to pregnancy. And so that's mostly what we do for that. And then you said something where I thought, oh yes, I have to, contingency management. So
what
we
types
tend to
of
do,
incentives you might use, yeah.
Yeah, so we, in my clinic, we're fortunate enough to have a grant where we can provide monetary incentives. It is limited, it is SAMHSA funding. And so other people could have this grant too, you just have to apply. But the most they can win is $15 on a day, and the most they can win over the year is 75. So it's really not a lot of money. And what we do is we have this fishbowl. We use like the VA fishbowl approach where there's papers in a fishbowl. The vast majority of those papers say like, good job, keep up the good work. And a few of the papers say $5, a few say 10, and a few say 15. No more than $75 worth of dollar money is in that fishbowl. And for their first negative screen, they get to pull a paper out. For their next consistently negative screen, they get 2 papers. If it's consistently negative, then they get more papers. If they're ever positive, it goes back to 0 papers, and the next screen, if it's negative, they get 1 again, and so they have to build up. And I will tell you, we actually, the biggest barrier to this is geography and whether your patients live close or far, because winning $5 is awesome if you just walked by clinic. But winning $5 is terrible if you drove 2 hours to get to clinic.
Yeah.
But the patients who live close honestly love it. And more than anything, they love coming to clinic and having someone celebrate 4 days of sobriety with them. Right? Because so many family members are so frustrated. They're like, well, we'll celebrate when you're sober a year, or, and they're like, this was so hard. I made it 4 days.
Right. No, and I think that is like the sharing in of that process and that reward pathway. And I know there are studies that look at different types of forms of incentives, but like you said, they don't have to be monetary. But monetary incentives and, like you said, the fishbowl approach and prizes and awards have been evaluated and very effective. But yeah, no, it is challenging. And I think the bottom line of all of this, whenever I give talks, is we need more effective interventions that are actually that can be used by persons, whether you're pregnant, with HIV, involved in the criminal legal system, what have you, for stimulant use disorders. And, that is unfortunately a huge problem that we have, especially if you don't have insurance. Yeah.
I add one more thing on contingency management. I will say there was like a lovely study that looked at whether targeting one thing or targeting multiple things, like if you have a patient with polysubstance use.
Yep.
And it is better to do one thing at a time. It still has positive effect. It has positive effect for multiple substances, but it's more positive if you target one at a time.
Yeah, that's a great point. I'm just going to ask this last question, and then we'll probably have to close up. But so just to give the caveat, specifically the topic was on substance use disorders and pregnant persons with substance use disorders. But one of the questions was, are co-infections, so I would say hepatitis C infections probably, and other comorbidities relevant for the pregnancy management plan options and pregnancy and fetal outcomes. So I guess the question is, would you do anything differently? Are different plans for, say, any of these other potential comorbid issues, or like potentially cardiovascular disease, or hepatitis C, hepatitis B, tuberculosis, anything that you would want to comment on, or that we could refer to a resource?
Yeah, no, the main thing would be there are certain drug-drug interactions. So one of the common ones we see is rifampin and methadone. So rifampin also is an inducer of hepatic enzymes and can lower methadone doses, or methadone concentrations. Sorry, so you have to increase the dose. And so you just always, whenever someone's on methadone, if you're adding or subtracting a new drug, it's always good to look in that drug interactions thing, because the methadone drug-drug interactions are, there's just too many to even remember them all. Just always check it. That's really the only thing I would do. And then disease specific. So neither methadone nor buprenorphine are renally cleared. So you don't have to renally dose them. They are both hepatically cleared. So if someone develops severe hepatic disease due to like rampant hep C or acute hep A or something, you may have to reduce the dose just because it may not clear as well. But that's more just like a watch and see kind of thing.
Yeah, like probably child's Pugh class C cirrhosis, but in those patients, we still don't stop their treatment.
We still don't stop it. No.
Yeah.
I just meant like acute hospitalization, acute fulminant liver failure.
Right.
We sometimes have to temporarily decrease, but we still don't stop.
Right. And just a caveat, there's really wonderful guidelines, the International AIDS Society USA guidelines for treatment of persons with HIV and at risk for HIV, and there's a section on pregnancy. And then also the DHHS guidelines. And then there are also guidelines, as you already discussed, about pregnancy and substance use disorders. So that was wonderful. And I wish we could go on and on and on because I love talking about this subject. But I guess we have to come to a close, and I have some reminders, so I will shift to those. So just for all of you who've made it this far, just, evaluations, information on how to claim the CME from this will be emailed to you by 5 p.m. tomorrow. And please give us your feedback. The important thing is this podcast going antiviral by Dr. Sag, Michael Sag. He's got a new episode coming up, or I guess has occurred. And then there's also an awesome overview. If you have not made it, or you did go to the International AIDS Conference in Munich, or you just like to hear Dr. Sachs and Dr. Klein are giving an overview of that on August 20th. And then another upcoming talk, Diagnosis, Treatment, and Complications of Diabetes in People with HIV, is also forthcoming. And September 10th, we have an awesome virtual course on opportunistic infections, and it'll be a case-based discussion of key OIs and real cases from the clinic by Dr. Benson and Dr. Badimo here. That looks awesome. And don't forget, CROI 2025 is going to be in San Francisco, March 9th to 12th, which will be great. And again, thank you so much for participating in this. And thank you, Dr. Leisch, for yet again a wonderful presentation. And thanks again. Take care, everybody.